Hello everyone, so we're going to be discussing now neurocutaneous disorders, and as I've said before, this should be done alongside the CNS neoplasms because there's quite a few kind of overlapping ideas. So we're going to be mainly talking about neurofibromatosis, tuberous sclerosis, and then a few other disorders such as ataxia telangiectasia. So just in terms of why neurocutaneous disorders exist, it's because, as you're aware, like the nervous system and the cutaneous systems, such as hair, skin, etc., and tegumentary systems, they all come from ectoderm. So when we have neoplasms, when we have tumours, when we have disorders, quite often they will involve both the nervous system and the integumentary system. So all these disorders all come from ectodermal origin. All right. So with that being said, let's start with neurofibromatosis. This is the most common neurocutaneous disorder which we're going to be looking at. And there are two major types. Neurofibromatosis 1, this is also called von Recklinghausen syndrome, and then neurofibromatosis 2 as well. They are autosomal dominant. Just a side note, a lot of the neurocutaneous disorders are autosomal dominant, including tuberous sclerosis as well. And they're related to mutations in tumor suppressor genes. I just want to briefly mention NF1 because that's the more important one in terms of pathophysiology. The NF1 gene naturally downregulates RAS, and you are most likely aware RAS is an important molecule in cell growth, cell differentiation, and if it's hyperactive, then it can cause cancer, or it can be one of the contributors to carcinogenesis. If we have a mutation in NF, neurofibromatosis gene, we don't have any of this negative regulation, so RAS is essentially very, very high, and that kind of then stimulates the MAP kinase pathway. And we can kind of understand that. This is more important for step 1, not really for step 2, but just to kind of jog your memory if you have already sat step 1. So in terms of the history and the presenting complaint, the diagnostic criteria specifically for NF1 is that you need 2 or more of the following. 6 café au lait spots. Okay, these are flat, uniform, hyperpigmented macules meaning they are flat sort of lesions on the skin. Just looking at this picture, this here, that is a macule. It's a café au lait spot, and they usually have very smooth edges, whereas for example in McCune-Albright syndrome they have café au laits, but they are very irregular edges, and they even refer to this as the coast of California, whereas the café au laits that we see in McCune-Albright are like the coast of Maine. They are irregular. We can also have 2 neurofibromas. These are benign peripheral nerve sheath tumours. These can be of any type, so they can be optic neurofibromas, or they can be in peripheral nerves anywhere else in the body. In terms, we also have freckling in the axillary or inguinal areas. The optic glioma, these are mainly seen in patients under the age of 6 years old. Lish nodules, okay, these are on the iris. So when you look at an iris, say for example this patient has blue eyes, a Lish nodule will kind of look a little bit like this. Like this, okay, like little hamartomas in the iris, okay? So you need two or more of them in the iris. Bone abnormalities as well, most commonly kyphoscoliosis, okay? And then a first degree relative with NF1 as well. If you have 2 or more of the following, then you're most likely to get a diagnosis. Realistically, in your step 2 examination, you don't really need to memorize that, but it kind of makes sense when you know the signs and symptoms. It's kind of just at least 2 or more of the usual signs and symptoms of NF1. And then just to show, these are neurofibromas, these little sort of polyp almost looking things. These are neurofibromas. They're called cutaneous neurofibromas, and they sort of extend out into the skin, and that's why they look pedunculated in the skin. Then the diagnostic criteria for NF2 are as follows. Okay, bilateral vestibular schwannomas. We have discussed this in the CNS tumours section. And then a first degree relative with NF2 and either unilateral acoustic neuromas or two or more of the following types: neurofibromas, meningiomas, gliomas, or schwannomas. Okay, and other features including seizures, skin nodules, kappa-Illet spots can also be seen as well. There is kind of like a nickname for NF2, which is also called MISME syndrome, which I believe stands for meningiomas, schwannomas, and there's also something else, so I would have a quick check of that, but it's called MISME syndrome, M-I-S-M-E. I think it might be ependymoma, meningioma, schwannoma, and I think it's just, this stands for something else. But anyway, look out for patients with schwannomas, meningiomas, and ependymomas. These are the three main tumours that are seen in NF2. So, regarding the diagnosis now. Diagnosis is usually clinical. You have a patient with the constellation of symptoms that we've just described, and we can go, this patient most likely has NF1 or NF2. Okay, the diagnostic criteria is based on signs and symptoms. An MRI of the brain, brainstem, and spine, usually with gadolinium, should be done to sort of search for a lot of these intracranial lesions. A complete dermatological examination should be done as well. Ophthalmological exam should be done, like a fundoscopy, for example. Bone evaluation and family history. Okay, once you know the signs and symptoms of NF1 and NF2, it should be obvious to you what kind of exams you should do. Auditory testing, of course, for the bilateral vestibular acoustic neuromas, and genetic testing's not required for diagnosis. So, if you have a USMLE question, you've diagnosed NF1, and it says, what would you do in order to consolidate the diagnosis? You would choose physical examination, searching for one of these. You would not choose DNA testing or genetic testing, okay? And a lot of students will naturally choose genetic testing because they know it's a genetic disorder, but it's not required. You can also evaluate for renal artery stenosis, and that's just because people with NF1 are at increased risk of secondary hypertension due to some form of renovascular lesion. And you should be carefully screening patients under the age of 6 for the optic nerve gliomas, just because it's so much more common in the pediatric population as NF1 is seen. Just a quick key fact, vestibular schwannomas, also known as the acoustic neuromas, present with ipsilateral tinnitus, hearing loss, and vertigo. This is because schwannomas, vestibular schwannomas, are usually located near the cerebellopontine angle, which is where your cranial nerve 8 is located. So a patient will have hearing loss and ipsilateral tinnitus, vertigo. Okay, and the treatment of choice is surgical resection for that. Regarding our treatment now, there is no cure for NF1 or NF2, so we're going to be doing symptomatic treatment. For example, somebody has kyphoscoliosis, we'll do surgery. Somebody has a tumour, we can remove and debulk. Vestibular schwannomas and optic gliomas will be treated surgically or with radiosurgery. They can't be left. And anybody who's got a meningioma, i.e. in somebody with NF2, this should be resected. There is actually some more medical therapy that is being sort of introduced now. Mutations in the NF1 tumor suppressor gene causes increased signal transduction of the RAS, RAF, MEK, and MAP kinase pathway. I mentioned this at the beginning. So we can actually use MEK and MAP kinase inhibitors such as selumetinib, and this can actually induce tumor regression. The reason why these are quite effective is because we know that this is due to, the NF1 is due to a mutation of RAS, or not RAS, but it's due to a lack of NF1 no longer downregulating RAS. So if this is gone, and my RAS is very, very active, that's going to stimulate the MEK and MAP kinase kind of pathways. So if I can have an inhibitor of these, this can bypass this problem and manage to kind of target the downstream signaling. Okay, so it's bypassing the problem. Excellent. So now let's move on to tuberous sclerosis. Tuberous sclerosis, like NF1 and NF2, is autosomal dominant. It affects many different organ systems, including the CNS, the skin, but also the heart, the retina, the lungs, and the kidney. Okay, so it's not just limited to the neuroectoderm and ectoderm embryonic origins. It's due to mutations in the tuberous sclerosis complex genes, and this is TSC1 and TSC2. TSC1 is called harmatin, TSC2 is called tuberin. I think on the top of my head they are located on chromosomes, I think 9 and 22 or 21. You might want to double check that. It's not really important for your boards, but it's 2 different chromosomes, not just one. And mutations in tuberin are more common than in harmatin. Okay. In terms of the history and presenting complaint, seizures are the most frequent presenting symptom. So always look out for seizures in these stems. Infantile spasms being the most common type. Okay. Tuberous sclerosis also presents with our ash leaf spots. The ash leaf spots are hypopigmented lesions, unlike NF1 where we see more café au lait, which are hyperpigmented lesions. And we usually see these ash leaves on the trunk and extremities. You will also see signs usually of mental disability and seizures, as we've said already. This is an ash leaf spot, okay? And these on the face, these are our angiofibromas, okay? That kind of are like lesions just like around the malar distribution. Other skin manifestations of tuberous sclerosis are the angiofibromas. I've already mentioned these, okay? These are small red nodules on the nose and in the cheeks in the distribution of a butterfly. We've seen that. We also have the so-called Sjagren patches. These are rough patches, usually seen in the lumbosacral region, and the reason why these can be differentiated from from an ash leaf spot is because they are rough to touch and they have an orange peel consistency. So they're usually textured, whereas an ash leaf is not. And then the very famous periungual fibromas. These are actually really commonly mentioned in USMLE questions, so do look out for those. They sort of look like, if this is someone's toe, let's say that's the toenail, they kind of look like a little lump just there, okay? Flesh-coloured lump, just in this sort of area, okay? So look out for those because they're quite often used in questions, in my experience. Other symptoms are secondary to small benign tumours that grow on the face, eyes, brain, kidneys, and other organs. So we can get congestive heart failure. This is secondary to the cardiac rhabdomyoma. Very high yield to know. We don't have many primary cardiac tumours, but the cardiac rhabdomyoma is one of them, and that is almost always seen in tuberosclerosis. Renal disease can also be seen from angiomyolipomas. That's again another very high yield association with the renal chapters and other carcinomas as well, renal cell carcinoma. Developmental disability is usually seen from brain lesions. We have different types of brain lesions in tuberous sclerosis. We have subependymal nodules, and we also have cortical tubers as well. The subependymal nodules are usually seen when you get like a CT or MRI, say that these are the lateral ventricles, very poorly drawn, but you'll see a little white nodule like here on your CT or MRI. Okay, so you'll see like a white nodule, and that's a subependymal nodule because it's just underneath the ependymal cells that line the ventricles, okay? And your cortical tubers are another thing. They haven't mentioned it here, but look out for them. Something called lymphangioliomyomatosis is a cystic lung disease, very rare cystic lung disease. That is also due to mutations in the tuberous sclerosis complex. LAM can present as a late manifestation of tuberous sclerosis, often in like the third or fourth decade, and it can also occur sporadically as well. And sirolimus, which is a target of rapamycin, i.e. the mTOR or mTOR inhibitors. This can slow the disease progression of LAM, okay? It's quite rare. I haven't seen it in any USMLE questions myself, but good for extra knowledge. Just a key fact now, infantile spasms occurring in children less than 3 years old of age and can consist of head bobbing, flexor spasms, extensor spasms, or movements that mimic the startle response. They may be associated with psychomotor regression or behavioral changes as well. So look out for this. It can be seen in other diseases, but it can be a sign of tuberous sclerosis as well. So how are we going to diagnose tubular sclerosis? Usually clinical, exactly the same as NF1. We're going to be looking out for the ash green, the ash leaf and the Sjagren's. We're going to be looking out for the angiofibromas, the ungual fibromas, cortical tubers, subependymal nodules. All of these things will point towards tuberous sclerosis. They've mentioned here that ash leaf spots can be enhanced by Wood's ultraviolet light lamp, but it's not needed for a diagnosis. In terms of imaging, I should be doing an MRI of the brain whenever I suspect TS. This is to look out for these subependymal giant cell astrocytomas, the subependymal nodules, and as I mentioned, the cortical tubers, which is usually seen in the periventricular or cerebrum areas. If the lesions obstruct CSF outflow, obstructive hydrocephalus can develop, of course, because they are seen in the ventricle areas. An ophthalmic exam is crucial in TS. This is to evaluate for retinal hamartomas and also some eyelid angiofibromas as well, but we're really looking for the retinal hamartomas. And of course, an echocardiography to do rhabdomyoma checking. So yeah, they've mentioned here, especially in the apex of the left ventricle, this is usually in about 50% of patients. Rhabdomyomas can also be seen in the interventricular space. I was always under the impression that it was more common for them to occur in the interventricular space, but they've also mentioned that it occurs commonly at the apex of the heart as well. A lot of those patients will go on to have heart failure, so that's why it's important to identify it early on. We should also be doing an MRI of the abdomen. This is to assess for the renal angiomyolipomas, even some cysts as well, but we're really looking for the angiomyolipomas. And of course, EEG activity, because seizures are the most common manifestation of tuberous sclerosis. Last but not least, for TS, we're going to be talking about treatment. So treatment, again, there's no cure, so we're going to be treating based on symptomatology, okay? One example could be cosmetic surgery for the angiomas on the face. Seizures are a really important part of management. So standard epileptic medications would be given first, but if they fail, we can give things like everolimus, the mTOR inhibitors. If somebody does have infantile spasms, then we should be giving things like vigabatrin, which can enhance GABA transmission. Okay, ACTH can be also used as an alternative as well. Surgical interventions may be indicated in certain settings, i.e. if somebody's got high intracranial pressure, maybe from the obstructed hydrocephalus that we'd mentioned from the cortical tubers and subependymal nodules, but also for patients who have got seizures that are from a specific foci, okay, or if they are resistant to vigabatrin and other medications. Okay, so that's the overall treatment of tuberous sclerosis. You're very rarely going to get kind of questions on this. It's usually going to be questions based on sort of presentation, diagnosis, what examinations to do, but it's really good, especially if you want to go into neurology or pediatrics, to know the treatment of and the management of TS. Great, and let's move on now to Sturge-Weber syndrome. So Sturge-Weber syndrome is due to a somatic mosaic mutation in the GNAC gene, and this is something that was covered in step 1, and this whole idea of a mosaic mutation, just to kind of jog your memory, It means that somatic means that it's not in the germline, so it's not passed on from a parent's gonads. It's instead in your cells, the somatic cells. And the mosaic just means that some of your cells have the mutation, some of your cells don't have the mutation, okay? And GNAC is associated with the GS signal pathway. So what's the kind of history and presenting complaints of patients with Sturge-Weber? So we have the most famous thing, which is the facial capillary malformation. This is also called the port wine stain. It's that really dark red sort of rash covering someone's face. And it's usually seen in the V1 distribution, okay, the ophthalmic distribution. This finding is in isolation does not qualify for the diagnosis of Sturge-Weber's disease, since the GNAC mutations constitute a spectrum disorder with isolated port wine stains as its mildest form. So Sturge-Weber is one extreme of the spectrum, and on the opposite end of the spectrum, you just have an isolated port wine. So if somebody just has port wine, they don't have any leptomeningeal malformations in the brain, then this is just an isolated port wine stain, okay? That's not Sturge-Weber. 20% of patients who do have this kind of spectrum also have the leptomeningeal capillary venous malformation either in the brain or the eye, and that is directly behind the port wine stain. And those patients can be diagnosed with Sturge-Weber. So whenever you see a port wine stain, as a doctor, you've got to be thinking, I need to do some form of testing to identify what's behind that port wine stain. Is there a capillary venous malformation behind it? Is this Sturge-Weber syndrome rather than just an isolated port wine stain? The brain parenchyma may be atrophic and contain calcified deposits as well. Some patients do have seizures, stroke-like episodes, hemiparesis, and even mental retardation as well, and this is related to, or most of it is related to the malformation in the brain. In regards to making a diagnosis, the preferred diagnosis is an MRI with contrast. This is purely because this MRI is better for soft tissue tumours rather than a CT, so it's more likely to pick it up. And the image may reveal intracranial calcifications, and these resemble a somewhat tram-like appearance. So I would advise you to kind of go on the internet, have a quick look at what that looks like. So yeah. And then finally, in regards to treatment, we do photothermolysis, can be used for the port wine stains. Some parents choose to get the port wine stains removed when the baby is young, to sort of save them from maybe any sort of facial disturbance when they get older. But some parents actually choose to keep it because they think that this is a part of their child, and it's part of their DNA, and that they want to sort of keep that with some pride. So you will kind of come across patients maybe who have these two different schools of thought, and none of them's right. It's really down to what the parent sees fit for their child. But one thing to keep in mind, port wine stains, they get darker with age. They're never going to regress. So even as a baby, it may not look that severe. As the patient does get older, this port wine stain will get darker and darker and darker, okay? Low-dose aspirin, beginning in infancy, can actually decrease the frequency of the seizures. So just bear that in mind. But of course, the main problem with these children in terms of their health is not the port wine stains, it is the seizures, okay? So anticonvulsive medications are a first line for that. Great, now we're going to move on to von Hippel-Lindau syndrome. So von Hippel-Lindau syndrome is an inherited autosomal dominant condition characterized by the presence of benign and malignant tumors in many different organs. The main areas that we look at are the retina, the CNS, the kidneys, and the adrenals. They've put pancreas here, but I was more aware of the retina, CNS, kidneys, and adrenals being the main four. It's caused by mutations in the von Hippel-Lindau tumor suppressor gene, and the good thing about step 2 is that you don't have to know the details about that specific gene, but it is related to vascular growth. that's what I would urge you to remember, because it can help you remember some of the signs and symptoms. Patients with type 1 von Hippel-Lindau syndrome are at very low risk of developing things like pheochromocytoma. But the type 2 von Hippel-Lindau syndrome, they've got a higher risk of pheochromocytoma. Okay? So in terms of my history, just before we go into it, I just want to give you a quick mnemonic that can help you remember it, and that is HARP. Okay? So the H stands for hemangioblastomas, the A stands for angiomas or angiomatosis, the R stands for renal cell carcinoma, and the P stands for pheochromocytoma. Okay, and we've already mentioned type 1 is not so much seen with the pheochromocytomas, whereas type 2 is more heavily associated with the pheochromocytomas. So with that in mind, let's just go through some of the physical exams that we can find. So hemangioblastomas are the hallmark of von Hippel-Lindau. They can occur in the CNS, especially the cerebellum, and we mentioned this when we discussed CNS neoplasms. Aside from the cerebellum, they can also occur in the spinal cord, and of course, if you're talking about signs and symptoms, if somebody has cerebellar problems, you're going to get things like ataxia, dysmetria, failed heel-shin test, dysmetria, maybe some truncal ataxia if it's more in the vermis. Okay, you can use your neuroanatomy skills to sort of identify that, and headaches as well. Retinal hemangioblastomas can cause vision loss as well, and these are usually identified on fundoscopy. 1/2 of all pheochromocytoma patients under the age of 18 have von Hippel-Lindau as the cause. And they, if you recall the signs and symptoms of pheochromocytoma, that's episodic hypertension, palpitations, sweating, anxiety, etc. And we talk more about that in endocrine. We've already mentioned a lot of the others, but we've discussed renal cell carcinoma. They can also have renal cysts. In terms of the pancreas, they can get the serous cystadenoma. They can also get endolymphatic sac tumours, which I find quite easy to remember because I'm like, the lymphatic system, very, very similar to like the vascular system. Also, in terms of the epididymis, we can get a papillary cystadenoma of the epididymis or the broad ligament in a woman, and then epididymal cysts generally. Okay, but the main ones I would say are more related to the HARP mnemonic. In regards to diagnosis, genetic testing for individuals with manifestations of von Hippel-Lindau is an important thing to do for a diagnosis. Just on a side note, tubular sclerosis and NF1, we don't need genetic testing, but for von Hippel-Lindau, it is advised in most countries. An MRI should be done. Why? Because of the hemangioblastomas, okay? We want to take catecholamines. Why? Because of the pheochromocytoma. And then we also want to do an audiologic exam to check for some endolymphatic tumours, which are usually seen in the inner ear. Okay, but again, if you know the signs and symptoms, it's kind of easy to know what tests you're going to do. And then in terms of my treatment, we need to be doing surveillance is the main thing. Again, there is very little treatment or cure of von Hippel-Lindau. We need to be doing surveillance and a couple of therapies to help, limit the disease. So routine surveillance of the abdomen can check for renal cell carcinoma. We can also check for pheochromocytomas and pancreatic tumours as well. We want to be doing retinal examinations annually to check for retinal hemangioblastomas. For patients with symptomatic hemangioblastomas, we should be trying to do a surgical intervention, okay? If they are unresectable, or if there are contraindications to surgery, then patients can benefit from belzutifan, which is a hypoxia-inducible factor inhibitor. I did mention at the beginning of talking about von Hippel-Lindau that you don't need to know the underlying cause, but I did say it was due to vascular growth. I suppose now we know the treatments, we can quickly recap the cause. Patients with von Hippel-Lindau, the underlying defect is a mutation in the hypoxia-inducible factors. It's actually an activation of hypoxia-inducible factors, HIFs. When HIFs are active, they trigger a cascade that leads to neovascularization and angiogenesis. And that's why we get hemangioblastomas, okay? HIFs also are related to renal cell carcinoma growth as well. So, with that being said, you can understand that if somebody's got a hemangioblastoma that's not really suitable for surgical resection, we can do a HIF inhibitor, and that is your belzutifan. In von Hippel-Lindau disease, levels of HIF1A and HIF2A transcription factors are elevated, causing an increase in physiological angiogenesis and an upregulation of VEGF and PDGF, okay? Basically what I've just described. And then finally, patients with renal cell carcinoma, and that renal cell carcinoma being more than 3 millimeters, should undergo surgical intervention rather than routine surveillance. Okay, so that's just remember that number of more than 3. Okay, which is quite easy to remember because von Hippel-Lindau gene is located on chromosome 3. So you can just remember that a renal cell carcinoma has to be more than 3 centimeters to be resectable. Okay, and von Hippel-Lindau has literally got 3 letters in his name. Good. And then finally, to finish off the neurocutaneous disorders, I'm going to be discussing ataxia-telangiectasia. So ataxia-telangiectasia, unlike the others, is autosomal recessive, and it's due to a mutation in the ATN gene, and this is part of DNA repair. The ATN gene is one of the core DNA repair molecules. And the ATN gene actually repairs double-stranded DNA breaks. So if we have the inability to repair double-stranded DNA breaks, then this can then lead to cell death and an increased risk for cancer. So with that being said, let's just cover just sort of the history and physical examination of these patients. Patients usually have, as the name implies, ataxia, and it's going to be cerebellar ataxia. And it's often first presenting symptom in infancy or early childhood. The patients may also present with ocular apraxia, which is the inability to control purposeful eye movements, cognitive impairment, extrapyramidal symptoms, and a peripheral neuropathy as well. Telangiectasias are common, and you're usually going to be seeing them in the face, the eyes, and the ears, so think in like the head area. And these patients also have an immune deficiency as well. And this is going to predispose the patients to sinopulmonary infections and interstitial lung diseases. And this is very, very high yield. And in fact, when I was first taught at medical school about ataxia-telangiectasia, it was in my immunology module under primary immunodeficiencies. Up to 1/4 of patients will also develop a malignancy as well, and this should make a lot of sense to you. Okay, if a patient has got the inability to repair DNA strand breakage, this is going to prevent my cells from doing DNA repair. So when there's DNA replication, this can increase the risk of a malignancy. Also lymphomas and leukemias as well. In terms of the diagnosis, usually it's a clinical diagnosis, but genetic testing is usually supportive of that diagnosis. So you could be checking for mutations in ATM. You can check immunoglobulin. Usually you see a low IgA. And then you can also check for AFP, and that's very high yield to know. We usually see elevated levels of the AFP molecule. And of course, imaging studies involving radiation should be minimized because that can then increase the risk of DNA strand breakage, and that can then increase the risk of malignancy. So we should minimize that. And then last but not least, treatment. There's no specific treatment existing for progressive ataxia and cerebellar degenerations, but the infectious element can be treated with antibiotics, and even prophylactic antibiotics can be considered in these patients. And that concludes our sort of discussion on the neurocutaneous disorders. I hope that was helpful. And as I've said at the beginning, it's best to do this alongside the CNS neoplasms video, so you can do those together.